So love being here, love Seattle Science Foundation. And this is one of the talks I really care about the most. And what we're going to have to first do is admit to ourselves that we are piecemeal laborers. And that's kind of a hard thing to admit. Here's my boring disclosures. Here's my real disclosure. I put in my 10,000 hours as a carpenter. My parents sat me down and said, we can't afford a private college and forget about med school. So we all kind of chipped in, did the most we can. And what I learned on the construction site is if you get an overuse injury, you lose your job, you can lose your house. So it's all about power tools. And somehow, I first came to spine surgery, you take this big metal spike and you jam it into a spinal cord and somehow think that was safe. Now, if you're walking by a neurosurgical room, they're not shoving big metal spikes into the, brain. So why are they using power tools up here? We were not using power tools in the spine. And this is a very haunting study. Scoliosis Research Society, the surgeons are 100 times more likely to have cervical myelopathy than the average person. I had it. I lost use of my hand once, had emergency surgery the next day, took a few months to get the strength back. So this is real. And this is one of my favorite studies now. They took neurosurgeons and neurologists, and 15 years into practice, the neurosurgeons had 10 times more problems than the neurologists. Maybe from having your head down all the time. And having your head down all the time could be a problem. The 90-degree glasses may solve it, but nobody really uses them. They're uncomfortable. They slow you down. Maybe looking up at screens will help. We'll talk about that in a bit. And every orthopedic group and multiple neurosurgical groups and spine groups have found that there are overuse problems. So we should just accept that. Now, I first pitched 2 different big companies about bringing power to spine, and people told me it's too dangerous. We'll never do that. One company said, okay, let's try it. This is a very smart engineer who now works for High Ridge. And she said, hey, let's put EMGs on you and on other surgeons when you do spine surgery. And she even put things up on my neck. I'm like, she doesn't know what she's talking about. Why would she put anything in my neck? And of course, she was right. The neck did matter. And so in the field of occupational medicine, if your EMG is greater than 20% maximum, while you're working, you're at risk for overuse injuries. So I think this might change things. We could sue hospitals, if we're at risk for overuse injuries.
Yes.
Yes. And you see the top manual using the probe, using the tap, using the screw. Everything that we do is putting us at risk for overuse injuries manually, but not on power. And this surprised me. The number one thing was the neck extensors. Who would have guessed that putting in screws and tapping your neck extensors are being overused? But they are, and that makes sense where we get these overuse injuries. So let's talk about different power tools that can maybe help us from not ending our career early. So early on, I used to go to Home Depot, and I'm not kidding. I'd go to Home Depot, I'd get all these different drills, I'd sterilize them until eventually I was told I can't do that anymore. But if you have soft hands, as Jens was talking about yesterday, am I allowed to walk there or do I walk off camera? I probably shouldn't. If you feel the medial wall, it feels hard, and you can bounce off of that and then feel the soft bone. So if you take a drill bit and run at full speed, you can go through hardened concrete. But if you make it move slowly, rotate really slowly, you can differentially feel the hard cortical bone, click, 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 versus the soft cancellous bone. Falls right into place. And here's the tools that we developed. Use a flexible drill bit, then use a dull threaded dilator. Why is it dull? Because one time I got an iliac vein with a sharp one. So let's picture, what would you do in this situation? Putting in an S1 screw, lots of blood comes out. Pretty sure it's iliac vein. What would you do? Flip the patient over, applied pressure for 30 minutes. It was fine, fixed it next week, didn't have to open the patient. Remember the basics. Apply pressure when it's bleeding, not a suction, pressure. Okay, I digress. So the average resident, when they put in the screws, is Jalen here? I don't see Jalen. Sorry to embarrass you. The average resident takes about 60 seconds to screw to put in. And what was interesting, we found out that when we put in the screws by power, there was less fluoro. And it's because you have more proprioception. And the engineer had another great idea. She basically put a GPS on a screwdriver versus a drill. And in blue, it's the manual screwdriver. It's all over the place. And the red is the drill. It's more like a vector, ray beam. So one could imagine if you're putting in a screw and wobbling, which you are, you're probably ruining the bone-metal interface. It's a less strong screw. And sure enough, those screws tend to fail more when you put them in by hand. So admittedly, this is a completely biased study. I picked 7 fantastic surgeons, taught them this technique, and I will propose to you there's no paper out there showing that more screws could be put in safer with less complications than surgeons actually using proprioception in their hands and feeling. So as we move towards navigation and robots, let's not lose this. Let's gain this. Now, a simple thing, if you put in screws and have your elbow above your shoulder, your rotator cuff will wear out by the time you're 50 years old. So with power, it makes it easier. Keep your elbows at your side, use more fine motion rather than big motion. And trust me, when you have a resident going like this, I'm fearful they're going to plunge. When you have a resident going like this, I feel much better. So ask for short screwdrivers. I'm not sure, but I think the shoulder surgeons have paid off the spine companies to make the screwdrivers really long. Ask for short ones. They make them. Okay, ultrasonic bone cutting tool. I said once in a talk that this was the best thing since sliced bread, but they told me I couldn't compare it to food for some disclosure reason. I don't know why. But it's wonderful to take off inferior facets. Cut, doesn't cause that bleeding you get out at the side. It also is great for osteotomies. It almost feels like cheating that you just boom, boom, cut through, you're done. Downside of that is it can cut through dura, and actually it burns through dura. So be very careful near the dura. So now robotics and navigation have this promise that, maybe, we can use our bodies a little bit less. Now, the truth is, though, that the way that robots work right now is not necessarily saving us from injury. Spine is kind of late to the game. General surgery has used this for years, and they still reported high rates of overuse injuries with robots. And at least the way the robots are now, you're always trying to line up sight. So, I have my poor spine fellow looking 90 degrees there at the screen. My poor resident is leaning out of the way of the lights or of the, visual field. So robots aren't quite there yet. I think what's going to help us a lot, and this is coming really soon, is you're going to have goggles, augmented reality. You're going to see the screen of where the screw is supposed to be, where it is going. It's going to be like a video game, and you can see it all in one place. You're not going to have to turn your head so much. And best of all, there's cameras on the goggles, so you don't have to worry about getting in the way of the eyes anymore. Now, the truth is, when I was preparing this talk, we did a scoliosis case. Put in 16 screws, you're closing in less than 2 hours. I was very happy. The next day, with a robot, I spent 1 hour and 20 minutes to put in one perfect screw. So robots are frustrating. They're slow. There's a big learning curve. It's worth it. It's a future. We're all going to get there someday. Maybe even Jens. Maybe not. We'll see. And I owe people a public apology. I've designed 5 lines of spine implants, and I just didn't know any better. I designed them for size 8 hands. And my pediatric spine fellow last year, Vivian Chen, with size 5.5 hands, is like, Dr. Skaggs, I can't use these instruments. And I looked into it, and sure enough, there's literature on people with small hands. So let's not make this a male-female thing. Just anyone with small hands can't use big instruments. So I think that we should demand, and our industry partners should help provide 2 sets of tools, people with big hands, people with small hands. It actually opens up markets in Japan and things like that. Okay, so what's new? So on the left is a typical high-speed drill, and this is showing how it can tear through dura. And on the right is a oscillating tool. So this is really brand new. And what an oscillating tool is, we talked about it yesterday a little bit, it's like a cast saw. It just goes 24,000 hertz, 270 degrees. It's kind of like vibrating. And when you vibrate a lot, you won't hurt soft tissue, but you can cut through bone like butter. And it makes a lot of noise. It's kind of scary. I think we have it in there. Everyone should try it. It's really different, and I believe that this is going to take over the market for things like robotics. And the reason why is it doesn't skive. And here's the case of a spondylolysis model. It's easy to skive there. And for those of you who are squeamish, don't look. You may want to turn your head away. Before I used it in a child, I made sure it was radically safe. It's that safe. This is the sharpest, most aggressive tip they have. Here's a new one that's about to be publicly released, I think, in a month. This will allow you to go into a pedicle and feel the way down, even better than a drill bit, go all the way down in one shot, and it won't hurt soft tissue. When we do this, it's about 30 seconds to screw start to finish. And now for the first time, when we're using these safe tools that are navigable, is that a good word? You can, for the first time, feel and see whether you're hitting cortical bone or cancellous bone. Yes, sir.
Quick question. Is that drill bit flexible like the other drill bits you showed earlier?
Yes. So I developed this for over a year. I just tried different thicknesses over and over and over. Yes, this is flexible, and the tip is not too sharp. So the tip will bounce off the cortical bone, and it flexes just enough. That's a good question. And so, in summary, I guess we're done. In summary, we want to mentor young surgeons, that's all you. Preserve your bodies, use power. It's not wimpy, it's actually smart. And it's also just intuitive that using less force around a spine improves patient safety. So I do now. That's my daughter in the middle. She's a PGY4 orthopod at Stanford. I try to design things and think of operations in terms of how could we preserve her as a surgeon long-term, rather than act like, boneheads like we did growing up. Yeah, that's it.
Love it. Can you go back to that slide? That was such a great talk that showed that of your flexible drill bit, that insertion technique with that funnel.
Yes,
graph.
Is my favorite slide. I love talking about that.
Yeah. So I just want to point out that I learned before I had the privilege of meeting David Skaggs from a Japanese surgeon named Dr. Abumi, and he calls that the Abumi technique. One of the biggest mistakes people do is when they use a Midas tool, like an MR8 matchstick, to make a small cortical hole and then just stay in that thing. And one further, there was that blue graph that shows what actually happens spatially, that GPS slide. One more, maybe two.
Oh, GPS. Go backwards.
Other way. Yeah, so the point there is that making a slightly larger insertion hole that then allows the proprioceptive self-guidance of the tool to follow the pathway of least resistance. It was a graph with a blue tracking depiction. I think one or two more forward. Sorry, put you on the spot here.
There we go.
So, if you study this blue, this is a funnel thing. This is exactly what I was taught, fortunately, 20, 30 years ago by Dr. Abumi. And you're doing this with a better tech solution. I think this is the key thing in terms of putting a precision pedicle screw is make your insertion point a little bit larger and then follow the pathway of least resistance. And the screw will be way bigger than that entry side anyway. So this is, I think, manifested right here. So you think exactly and have produced in a new era tech application, something that Professor Abumi taught us many years ago.
Yeah, and it's almost like a Taoist exercise of allowing it to follow the path of least resistance, rather than pushing it through the cortical bone.
Yeah. And again, I really love how you teach your fellows and residents to trust their hands and their proprioception more than their eyes, and not getting into this, again, the term funnel comes up, this kind of a very narrow-viewed kind of a perception. So if you now balance this inside of this blue graph with image guidance, where do you place a priority in terms of weighing the evidence? So here you have a screen and the computer tells you to go one way, and then your feeling and your knowledge leads you to another way. How do you balance those two input options?
I think in the best of all worlds, we don't have to give up one for the other. Let me see if I have. So with the with new tools that are coming out, we can feel even better. So that, I think I have to say, there's only one company right now, DuraPro, no question, there'll be lots of other companies making it because it's so good. The vibrating tool, you can feel as good or better than the drill bit, and we can see it. So I think we don't have to give up feeling for seeing. The question is, moving forwards, we have to feel and see. So I think it should be additive. Now, the other thing that I think is worth bringing up, especially as we move towards robotics, is the high-speed drills can deliver a lot of energy and cut through a spinal cord. So if you deliver a high-speed drill into a spinal cord, that could be an irrecoverable paralysis, and it has happened. That's why if you're using high-speed drills in robots, you never want to go, in my opinion, more than 5 millimeters with that drill, because if you're off, irreparable damage.
Feel and see.
Yes, sir.
Tell one thing, coming with a microphone. Who's the hand up? Oh, here. Tell us who you are, where you're from.
My name's Ryan. I'm from University of Florida. Things with the cast saw that we run into issues with is obviously generating too much heat. Is that something that also happens
No.
with the oscillating? Mm-hmm.
It does not happen with the oscillating tool. I've been worried about that. So as soon as I use it, I take it out and touch it, actually. And I think it's because in the human body, there's just enough liquid to keep it self-cooled. I'm not sure. But that was a big theoretical concern. Yeah.
Great question. Many more things to discuss, but opportunities later maybe. Let's move on to the next lecture. Thank you, Dr.
Thank you.
Skaggs.